Hi, good afternoon all. Welcome to yet another session of Vertical Integration Program. Today we have chosen a very practical and very clinically relevant topic, renal function tests. Before going into the discussion, I would like to introduce the expert panel. Dr. Rajesh sir, who's the HOD of Nephrology, Amrita Institute of Medical Sciences. Sita Lakshmi Madam, who's the head of Nephropathology, Amrita Institute of Medical Sciences, and Dr. Pooja, who's a faculty of Biochemistry, Amrita Institute of Medical Sciences. I would like to start off by asking Rajesh sir, sir, what are the basic tests that we do to understand the renal function?
Thank you, Dr. Anu, for the introduction. The basic tests which we use for evaluation of kidney disease are very simple. They are basically blood test and urine test. So blood test, blood urea, serum creatinine. This will tell you what is the intensity of the renal dysfunction, if any. These are biochemical tests. The other test is urine test. It is said that the urine is the mirror of the kidney. So you'll have to do the urine test. Urine test is basically, you say urine analysis. Urine analysis includes physical, chemical, and then microscopic evaluation. The third important aspect of evaluation is an ultrasound abdomen of the kidneys, which includes ultrasound abdomen and other organs also, which will give you an idea regarding the structural and anatomical issues of the kidney.
Thank you so much, sir. Next question to Pooja ma'am. Madam, would you like to shed some light into the biochemical tests that are used to assess the renal function, and how on the basis of those tests you can correlate it to the clinical aspects as well?
There are many different tests that can be used for the diagnosis of renal diseases. So the most important one is the urine routine test, and then you have the test for glomerular function, tubular function, and kidney injuries. So the first one is urine routine test, and in urine routine test, the first thing that we look for is the physical properties of the urine. So you will look for the color, any abnormal color is there, any abnormal odor, abnormal appearance, something like that. And next you have the chemical test. So under the chemical test, you look for the pH of the urine and presence of abnormal substances like the presence of protein or glucose or ketone bodies or bilirubin. All these abnormal substances present or not. Then there is the microscopy. In microscopy, we are looking for urinary cast or any crystals or RBCs, all these things. So the easiest way to do this test is to go for a dipstick test. So dipstick test is you just need to collect a urine sample, and there is one strip, and this particular strip is impregnated with the reagents at different spots, and you just have to dip it, and then you have to see the color change. So this color change is compared, so there is a comparing chart will be there. We have to compare this color to the chart, and in that way we can analyze if any abnormal substances are present or not. And then you have the test for glomerular filtration, and the most important ones are the urine creatinine and the the serum urea. So the serum creatinine and serum urea, and both these will be increased in case of a renal abnormality and injury or something. But the problem with the urine creatinine is that it won't be increased like suddenly or anything. Only if there is a significant functional loss, then only will be the serum creatinine be increasing. The other test is your creatinine clearance test is said, but it is a little more difficult to do because you need a 24-hour urine sample. And the other one is the estimated GFR. It is a calculated value. You have different formulas for calculation, like the MTRD formula is there, CKD EPI formula is there. And then the other test is serum uric acid can also shed some light into this. And then comes the test for tubular function. So tubular function, we are basically looking for the concentrating and the diluting capacity of the kidneys. And here this include tests like the specific gravity or urine osmolality, and also there are water loading and water dilution tests which can be done if needed. And they also test to look for tubular absorption, and tubular secretion tests are also there. Then you have for if renal injury, you can go for proteinuria, look for proteinuria or microalbuminuria.
Thank you, Dr. Pooja, for that detailed explanation. My next question to Sita Lakshmi ma'am. Madam, there are many abnormal things that may be found in a urine routine examination. Like in normal urine routine examination is not supposed to contain RBC, cast, and those kind of things. So, can you shed some light into what a normal urine routine should look like, and if there are certain abnormal things which are seen, how will you correlate it to the renal pathology?
Yeah, the urine test, like whatever Dr. Pooja has told is like you can do it as a strip test. So that itself may tell you like there are some WBCs in that, because there is a glucose esterase test in that, and it can also like detect like our presence of RBC or hemoglobin in that. So indirectly you know that they are there in the urine, but for a definite evidence you have to see the urine microscopy. So in the microscopy you can actually, it is a concentrated urine, they use centrifuge the urine and take the deposit and see it under the microscope. So that will show you different types of cells if they are present. You can see the RBCs, WBCs. So if the sediment is showing more than 2 RBCs, that is significant. That indicate a bleeding from somewhere in the urinary tract. And if you are seeing like more than 5 WBC or pus cells, it's also significant. You can also see other cells like the epithelial cells and all in that. The other important thing is, if you are seeing a normal looking RBC, it is hematuria with RBC. But if you are seeing a structurally abnormal RBC, they are also called dysmorphic RBCs. They are indicative of glomerular injury. Otherwise, RBCs can be there in the urine in an infection or injury starting from the kidney to the urethra. Okay, once the RBC is dysmorphic, indicate that it has like the RBC has come from the kidney. And if you are seeing casts with RBCs in that, it indirectly tells you that the casts are formed in the distal convoluted tubule and collecting duct. So in that, if the RBC is there, it tells you that the RBC has come from the glomerulus. Okay, so it's a glomerular injury. So if there is an RBC cast in the urine, it directly tells you the origin of the RBC. So in that way, the urine microscopy helps. You can also see granular cast and WBC cast depending on whether it is like a glomerulonephritis or pyelonephritis. And the other thing which is important is crystals. So in the stone diseases, sometimes you can see that same crystal in the urine, like the oxalate crystal, uric acid crystals and all. So these are the important things in the urine microscopy.
Thank you so much, ma'am, for telling all the findings with the most common diseases. My next question is to Rajesh sir. Rajesh sir, if a person presents with frothing of urine, as a nephrologist, what are the first line tests that you would like to recommend?
That's a good question actually. Once we see patients in the OPD, 20-30% of patients are actually like this. They give a history of frothing going on for months together, and they are not very sure what is the cause of that. So frothing, we are mainly concerned and to find out whether he is leaking protein in the urine. Protein, usually, predominantly it is albumin. It can be non-albumin proteins also. So the first test which we would like to see is again urine routine, to see whether the patient is having proteinuria or albuminuria. The non-albuminic proteins are also there, which are usually the tubular proteins or the light chain proteins. So there are 3 levels at which we look at protein. One is glomerular proteinuria, second is tubular proteinuria, and third is overflow proteinuria. So glomerular proteinuria is by and large the most common form. So that is the first thing you do. Urine routine to look for albuminuria or proteinuria. So that is, as Dr. Pooja and Dr. Sita said, you do a urine dipstick test. The urine dipstick is positive. That means that this patient is losing more than 300 milligram of albumin in the urine in 24 hours. It's an indirect test. It's also 1+ or 2+. There are various ways to semi-quantitatively assess what is the amount of protein loss. So more than 300 milligram of protein in 24 hours indirectly. is approximately is the value if the urine dipstick is positive. But the urine dipstick can be still negative if the patient is having microalbuminuria. As Dr. Pooja said, microalbuminuria is one of the earliest indicators of kidney damage, especially in a patient with diabetic nephropathy. So looking for microalbuminuria is probably the earliest test we suggest in a patient who is a diabetic. So microalbuminuria means 300 milligram to 30 to 300 milligram in 24 hours. That is the range, or 20 to 200 microgram per minute. So if the patient is passing albumin in this range, the urine dipstick will not pick up. The urine routine will be negative. So you usually ask for urine routine and a urine albumin creatinine ratio to look for microalbuminuria also. So if microalbuminuria is there, then urine microalbumin test will pick up and urine albumin creatinine ratio will also pick up the microalbumin. But by and large, frothy urine, generally, if the patient is having frothy urine, usually patient will be having dipstick positive proteinuria. Microalbuminuria will not be having significant frothiness of urine. Now, to discuss one step beyond this, to say that patient has clearly a glomerular pathology, patient should be passing a nephrotic range of protein. Nephrotic range of protein is more than 3.5 gram of protein albumin in 24 hours per 1.73 meter square. So if the patient is having more than this 3.5 gram in 24 hours of albumin in urine, we are fairly sure that the pathology is glomerular. But having said that, there is a very important statement I would like to make here, that subnephrotic proteinuria also can be glomerular. Whereas tubular proteinuria is never glomerular. Tubular proteinuria can never reach nephrotic range proportion. This is very important. So if a patient comes to you with 2+ proteinuria, you assess the 24-hour urine protein. That is the next thing you do to assess what is the quantity. So if you have a 300 to 1 gram of proteinuria, you can always reconfirm with the 24-hour urine protein, or you can reconfirm with the urine albumin creatinine or urine protein creatinine ratio. For example, if the urine protein creatinine ratio is 0.7, that means the patient is passing into 1000, 700 milligrams of protein in 24 hours approximately. We can reconfirm it with the 24-hour urine protein. So urine dipstick, urine albumin creatinine ratio, or urine protein creatinine ratio, and 24-hour urine protein will tell you whether patient is passing albumin, what is the amount of albumin, and whether it is in nephrotic range or not. This is how you go about regarding this frothiness of evaluation of frothy urine.
Thank you for that crisp explanation. Just an additional question as from a layman's point of view. Are there any special considerations to do when you do an ACR or a PCR? It's like, should we give an early morning urine sample, or any time urine sample would be?
See, to pick up, there are a lot of dynamic variations in protein. So if you exert a bit, that's why if you have a patient with microalbuminuria, always you have to reconfirm at least 3 times to confirm that patient has persistent microalbuminuria. If you are febrile, if you are exerting, you can have some microalbumin. So always you advise a urine albumin creatinine ratio after a period of rest. So early morning sample is the best test to understand. But still, having said that, if you are having significant proteinuria, it is usually persistent. So anytime you pick up, you check, it will get. I did not discuss regarding overflow proteinuria. See, even if the dipstick is negative, you do a 24-hour urine protein and see that the patient is having significant proteinuria. It is a non-albuminuric protein, because dipstick will pick up only albumin. It is only sensitive for albumin. So you can have a dipstick negative proteinuria but significant protein loss, either due to tubular proteinuria, which never crosses nephrotic range, and overflow proteinuria. Overflow proteinuria most common is myeloma, multiple myeloma or plasmacytosis gravis, wherein the light chains are the light chains are excreted through the kidney, are filtered out, but the kidney is unable to reabsorb. It is exceeding the reabsorptive capacity of the urine, and it is just like overflowing into the kidneys, into the urine. So there is overflow proteinuria. So overflow proteinuria is one condition which we have to always rule out when a patient comes with significant amount of proteinuria and urine albumin is negative.
And it is very counterintuitive also, sir, when patient presents with frothing and albumin is...
Yeah.
Okay, so thank you for that
You can check the urine routine, and you can check a urine protein creatinine ratio. Protein creatinine ratio will be high and urine dystrophic will be negative. That is a clue to look for. There may be other clues also, because patient with significant nephrotic range proteinuria with a probable myeloma. Patient may be having anemia, very high ESR, renal dysfunction, albumin globulin reversal. Patient is having bone pain. There may be some clues to evaluate also.
Thank you so much, sir. My next question is to Pooja, ma'am. Madam, can you tell me the principle, the clinical significance and the methodology of this very important test called creatinine clearance?
Creatinine is basically the end product of creatine metabolism. Creatine is converted to creatinine by a spontaneous non-enzymatic reaction. It is happening in the muscles. So the thing about creatinine is that it is produced continuously in the body in a constant rate, and it can be cleared easily from the kidneys. It is not reabsorbed in the tubules, but a very small amount is secreted from the tubules. So coming to the clearance, clearance can be defined as the amount of plasma which is completely cleared of a substance in a unit time. That's what is clearance is. So there are many different clearance tests, including the urea clearance test is there, inulin clearance is there. But the most commonly done is the creatinine clearance because of the above properties of creatinine. So creatinine clearances can be hence defined as the amount of plasma that is completely cleared of creatinine in a unit time, and the unit is ml per minute. And there is a formula for calculation for the it is U into V by P, where U is the urine concentration of creatine, V is the volume of urine flow, and P is the plasma concentration of the creatine. So for doing a creatine clearance test, first thing is we need to collect a 24-hour urine sample, and along with that we will be taking one blood sample also. And the methodology is like the first sample, morning sample of urine, it is voided, it is not collected. From that point, for the next 24 hours, you will be collecting all the urine that is voided by the patient. And from then we will be calculating the values. So the interpretation is like actually the one more thing about creatinine is like the creatinine clearance is roughly is equal to the glomerular filtration rate, but actually it is slightly overestimated because of the tubular secretion, but it is actually, it's not very significant amount. And the interpretation is like 90 to 120 ml per minute is considered as normal, and creatinine clearance it can be used for staging of CKD also.
Thank you so much, ma'am. Ma'am, my next question is to Sita Lakshmi, ma'am. Madam, coming to your core area, madam, the most common renal diseases that we see in our area, like as Rajesh sir said, compartmentalizing it into glomerular diseases. Can you shed some light into the most prominent renal biopsy findings, characteristic renal biopsy findings of the common renal pathologies that we encounter?
When a renal biopsy is done, this is that will be like after a complete detailed clinical evaluation and biochemical test and all. So not all cases of which comes to nephrology have a biopsy, because most of them are treated with the clinical finding, examination finding, and the biochemical and urine examination finding. Most of the diagnosis is made, and there are certain indications for doing a biopsy. So one is like Dr. Rajesh has already told, like the frothing of urine. So that is like one clinical syndrome which is called a nephrotic syndrome. Patient is losing protein more than 3.5 gram per day. So that is causing all the changes in the body with edema and proteinuria, massive proteinuria. So in that, like the diagnosis usually in a younger child, which is thought of as a minimal change disease, where like you won't see much change in the renal biopsy, but you know that there is some damage to the kidney, which is like causing the proteinuria. So when a renal biopsy comes, actually you have to evaluate it by light microscopy, doing the stains, like the routinely used stain is the H&D stain, and you can use some special stain to demonstrate the basement membrane, the immune deposit, and the amount of collagen deposition or the fibrosis which is developing, the tubular atrophy and all those things. So special stains are used for that. And the other one special test in the renal biopsy is immunofluorescence test because many of the glomerular diseases are immune mediated. So by light microscopy you won't be able to see the immune deposit. So you have to have a fresh tissue which is cut and stained with immunofluorescence with the corresponding antibody which is poured on the kidney biopsy tissue, and you will see lighting up of that immunoglobulin or complement or the light chains on the renal biopsy using a special epifluorescence microscope. So then the other test which is done in renal biopsy is a electron microscopy. That will give you the ultrastructural changes in the biopsy, where the exactly is the immune deposit deposited, or what are the structural changes in this thing, whether it's a podocyte damage, whether it is a damage to the basement membrane, or whether the immune deposits are there in the subendothelial region. All these things it can tell, and it can even tell some of the fibril deposition diseases like amyloid and all those things electron microscopy will tell. So in a routine case, the common indications are like nephrotic range proteinuria. In children, predominantly it is minimal change, or a focal segmental glomerulosclerosis. And little more adult patients, you will get focal segmental glomerulosclerosis or a membranous type of glomerulopathy, in which the glomerular basement membranes are thickened and it is losing protein. The other group is which is presenting with hematuria predominantly. That will sometimes it will also have a little bit of proteinuria, but subnephrotic range. So those cases, whatever we see in the biopsy are sometimes IgA nephropathy, lupus nephritis, then post-infectious or immune like infection-related glomerular nephritis. All this will present like and subnephrotic proteinuria and hematuria. Then in adult patient, the other very important biopsy finding we have is in diabetic patient. Many of them like won't get biopsy. There are specific indications for a patient to get a biopsy in diabetes. You will see like the Kimelstein-Wilson nodule classical finding. You can also see some additional findings, sometimes the associated other diseases like an IgA nephropathy or membranous nephropathy, or the patient may have some chronic tubulointerstitial diseases with that, and we can also see the vascular changes also. So by renal biopsy, you can find out actually which compartment is maximally affected, how much it is affected, what are the acute changes, what are the chronic changes in each compartment, and depending on the indications and the clinical examination and the biochemical test, we correlate it with the biopsy findings and interpret it accordingly.
Thank you so much, madam, for the detailed yet crisp explanation into the most common diseases that we encounter in clinical practice. Rajesh sir, my next question is to you. Suppose a patient comes to your OPD with complaints of high colored urine, cola colored urine. How would you like to further evaluate that patient?
Again, that's a very good question. Depends on a lot of factors. You'll have to see what is the patient profile. For example, a child comes with a history of cola colored urine. We always have a diagnosis of post-infectious glomerulonephritis in your mind. So we'll ask whether the patient is having an antecedent infection, especially a sore throat or a pyoderma 2 to 3 weeks back, whether the patient is having obvious skin lesions which is already healed, and what is the patient's presentation, whether the patient is hypertensive, patient is volume overloaded, whether the patient is dyspneic because of pulmonary condition, is there a renal dysfunction. So that is in your mind. So an evaluation based on that, including urine routine, whether urine is showing hematuria, whether urine is showing RBC cast. RBC cast is again very clearly, Dr. Siddha told that if you have an RBC cast, the pathology is glomerular. There is no. Okay, so we'll ask the biochemistry team to check whether the patient is having RBC cast or not, and what is intensity of renal dysfunction. Whether the patient is having an acute kidney injury, the creatinine is high, or her age, is a patient hypertensive, and certain investigations like complement ASO titers will tell you whether it is an immune complex, and basically immune complex mediated acute glomerulonephritis. So that is one group. If you have that in mind, we will evaluate in that line. Suppose a child comes with just a hematuria, there is nothing. There is no edema, there is no hypertension. Just a hematuria, which has been incidentally detected for evaluation sometimes. Then we have a lot of other diagnoses, like hereditary nephritis, where the patient is having a family history of hematuria, like Alport syndrome, where the patient is having a family history of other systemic involvement. Is there any syndromic diagnosis coming in? And whether the patient is having, we evaluate for Alport, like eye changes, sensory neural deafness of the eyes, all these we need to evaluate. So that is another thought process of the patient. Then the patient is coming in with significant extrarenal features. So always when we see a patient, we will try to correlate a renal diagnosis with an extrarenal diagnosis. So what is a renal diagnosis? Is it, as doctor said, is it acute glomerulonephritis? Is it a nephrotic syndrome? Is it a nephrotic syndrome? Or this is just a CKD or AKA with a bland urine sediment? This is the broad thought process. So if a patient is coming with features of a multiple systemic manifestation, ongoing fever, significant joint pains, patient has alopecia, patient has significant photosensitivity, rashes, then you know that patient is having a systemic disease. Mostly it's a vasculitis. Systemic vasculitis can be SLE or systemic vasculitis, a discal agenosis which has involved the kidney, and there is a renal involvement because of that. Sometimes children can come with HSV. HSV also presentation can be like significant rashes, especially lower limb rashes, and the patient is having hematuria. So again, HSV is also a form of HSV nephritis. It's an acute glomerulonephritis.
Immune complex.
So
IgA
vasculitis. So these are all in maybe in a child or an adolescent. All these diagnoses will. Suppose an adult walks in with hematuria. Again, the same thought process is there, but we have certain different thoughts. So is it an IgA nephropathy? The most common cause of a patient with microhematuria or even macrohematuria with hypertension, with proteinuria and renal dysfunction, the most common diagnosis is IgA nephropathy. So in such situations, you will be forced for a biopsy. We will have to confirm whether the patient.
So it's only diagnosed by biopsy.
IgA nephropathy.
Because IgA has to be demonstrated in the renal biopsy to tell that it is IgA nephropathy, because all other findings can be there in other diseases also. So by immunofluorescence, you have to demonstrate IgA in the mesangium. Then only you can tell that it is an IgA nephropathy.
So basically, it boils down to whether you are dealing with a proliferative glomerulonephritis or a non-proliferative glomerulonephritis, and especially an adult is coming in. Non-proliferative, as she rightly said, diabetic nephropathy is also a non-proliferative, but whether we don't need a biopsy to confirm, because there will be other evidence of, there will be proteinuria, there will be other evidence of neuropathy, there will be significant retinopathy. So all these go hand in hand. So we know that, okay, this patient is diabetic nephropathy. Other non-proliferative glomerular disease, basically primary glomerular disease like FSGS, membranous nephropathy, wherein you see basically proteinuria only, and may or may not have, hematuria may or may not be that. Usually it is not there. So that is the thought process. Then the patients who are coming with significant multi-system involvement, like patient is having a malignancy and he has come with microhematuria. Okay, then you have no patient has a thrombotic microangiopathy, he has a renal dysfunction. SLE again, coming to you, patient is having significant multi. It is generally unusual to have a patient with SLE walking in and we giving the diagnosis, this is lupus nephritis from the biopsy. Patient will be having some telltale evidence of extrarenal symptoms to start with. Maybe they have ignored it or not very prominent, but usually they will have some symptoms. So the patient who is coming to us with features of lupus nephritis are usually class 4 lupus nephritis, and they will be having some evidence of extrarenal symptoms. This is how we look at it. And before I conclude the answer to this question, one important thing is diabetic nephropathy. Again, I would like to re-emphasize diabetic nephropathy. Significant 70 to 80%, maybe 90% will not need a kidney biopsy for confirmation. We know what is what from the other extrarenal manifestations. But there are certain situations wherein a diabetic nephropathy has to be confirmed or ruled out, or maybe we need to confirm that whether is there anything else other than diabetic nephropathy by a kidney biopsy. There are certain situations wherein patient has a proteinuria of hardly 1 gram. Suddenly patient has come with a proteinuria bursts into 5 gram. So there is a super added glomerular disease which has come in. 1. Now, diabetic nephropathy is a non-proliferative glomerular disease. Hematuria, microhematuria or macrohematuria, RBC cause we don't expect. Suddenly patient is coming with significant hematuria, micro or macro. and patient has a acute renal dysfunction which is not going in line with the usual temporal profile of GFR worsening diabetic nephropathy, then you probably are dealing with maybe an IgA nephropathy, or maybe a post-infectious glomerulonephritis, or maybe a thrombotic microangiopathy, which is superadded on diabetic nephropathy. In such cases, again, be biopsy. Third situation wherein you think of a biopsy is patient is having a renal dysfunction, which is now the renal dysfunction has suddenly taken a different turn, and it is worsened very fast. There is no other clue but the renal function was. So in that case, we thoroughly evaluate, is there a vascular issue, is there a neurovascular disease, is there an ischemic nephropathy, is it a cardiorenal syndrome? In that case, there is no biopsy. If everything is ruled out and significantly the disease is worsening, again we will resort to Dr. Sita's help. We do a biopsy and find out are we having anything superadded on that. So we have picked up a lot of patients with multiple myeloma, light chain deposit disease. A patient coming with nephrotic range, suddenly the proteinuria is worsening and renal dysfunction is worsening. Anemia, persistent anemia, not getting correct. Renal dysfunction is not that severe, but anemia is significant. We expect the renal anemia to come in when the renal function is worsening, but anemia is disproportionate. Renal function is worsening, sudden worsening of proteinuria. We do a biopsy, we have picked up a lot of light chain deposit disease and plasma vessel dyscrasia. So these are all thoughts in our mind, wherein on a case-to-case basis, we'll decide on kidney biopsy.
Thank you so much, Rajesh sir. It was an umbrella explanation into all that. I don't think anybody can in such a short time explain so many, including the clinical aspects. And just for a confirmation, sir had told the temporal profile of a diabetic nephropathy, the rate of worsening of GFR, if I'm not mistaken, it is 8 to 10 milliliter per minute per year. 10 milliliter per minute per year if it is anemic.
Unmodified. If you do an ACRB, it comes down to half.
Yeah. So even that has to be taken into consideration, right, sir? What drugs he's on.
Are you on treatment? Yeah.
Thank you so much, sir. Thank you so much. Next question to Pooja ma'am. Ma'am, can you shed some light into the basic tests like blood urine nitrogen is used globally. Here we use blood urea serum creatinine to assess whether it's an AK or CKD, and also if any new biomarkers are there which are under trial to assess the renal function like cystatin C. Can you shed some light into
blood urea, nitrogen and creatinine, the ratio. First thing is that the creatinine and urea, they can be done, they are easily done. You need only a random blood sample from the patient and the ratio is calculated, and normally the ratio is between 10 to 15:1, and in case of a proper renal disease also the ratio will be like that only, because in a proper renal disease the urea as well as the creatinine will be increasing. And in case of a pre-renal azotemia, what is happening is the ratio will be more than 20:1, and coming to post-renal obstruction, in that cases the ratio will be between 15:1 to 20:1. So it can be used to differentiate the reason for the particular disease. Then a newer biomarker coming to that, you have cystatin C. So cystatin C is a low molecular weight protein. It is produced by all the nucleated cells in the body, and like creatinine, it is also produced in a constant rate continuously in the body, and actually it can be used as a instead of creatinine it can be used also. And also one advantage is that cystatin C, it is not dependent on muscle mass or gender of the patient or the age of the patient. Diet also, it doesn't affect cystatin C levels. Then coming to newer markers, there are markers like KIM1, like kidney injury molecule 1, used for the tubular abnormality, diagnosis of tubular abnormality. You can also use beta-2 microglobulin for the diagnosis of the same, and something called NGAL is also there. It is a biomarker that can be used for assessment of acute kidney injury. So this particular protein, it would be increasing within 2 hours of acute kidney injury. So these are the new biomarkers.
Thank you so much, Pooja ma'am. Because
one additional point, cystatin C is actually cystatin C is useful, as she rightly said. See, a patient walks in, and his creatinine is always 1.5, 1.6. The urine sediment is bland. There is no proteinuria. There is no hypertension. There is no metabolic syndrome. So obviously, we see such patients commonly like this with some features of metabolic syndrome. They'll be having hyperuricemia, they'll be having fatty liver with mild renal dysfunction. So that is part of the metabolic syndrome. So we convince them to cut down the weight, maintain a healthy lifestyle, control the uric acid, control the dyslipidemic status, avoid smoking, and then maintain diet. But there are certain situations wherein a young person coming in, fairly well built, but always his creatinine is 1.4, 1.5, but everything else is normal. So we are concerned whether something to do with the creatinine alone. So got it. So patient may be a bodybuilder. He may be using excess proteins. So it may be a muscle injury related issue also. In that situation, cystatin C helps. If cystatin C is normal, then we can safely say that there is no issue. But if cystatin is abnormal, we can still say there is mild renal dysfunction which is there, which needs further evaluation.
Sir, and generally coming to creatinine, if you is there any standard like clinically assessing? If you say a really muscular person who's not on supplements but genetically muscular person, should we expect a higher baseline creatinine for such?
Yeah, this question is usually asked, but practically we see that very muscular person sometimes creatinine may be 15-20% more than that. Has nothing.
It's not a cause.
We check the creatinine clearance, and sometimes people ask for a DTP renogram also to check what is the GFR like. So usually those GFR will come as normal. For example, see, we regularly check the GFR of the donors, potential donors, with creatinine with the DTPA. That's a protocol. So generally the DTPA of the GF of a donor. Usually our donors are in the range of maybe around 45 to 55 to 60 because parents. Their GFR will be somewhere around 75 to 80 only, not more than that. To see a GFR and DTP renogram more than 100 is exceptionally rare. It is usually, I'm talking about DTP GFR. Their creatinine is only 0.8 or 0.9. So there is a lot of things which we need to consider before telling that this patient has renal dysfunction. So the EGFR often helps. And usually we try to correlate with other formulas also. Suppose if the creatinine is normal and it's a practical thing. The donor is coming and father is a potential donor. Creatinine is 0.8, 0.9, you're fine. But you do the DTPA. DTPA comes as 70 or maybe 65. So you're not very sure whether he is having a low GFR. So you calculate according to the age whether this GFR is okay for him. Still we feel that the GFR is slightly less. We go for this CKD EPA. We go for a U by PA, proper U by P. We collect the 24 urine protein, 24 urine creatinine, get the plasma creatinine and see. And UBP comes as maybe 95 or 100. So we are okay. So it is actually an average of because all these calculations have some failure, some errors. So you get an average and get a feel that okay, this person is fine to donate. So that way we have fairly good exposure to normal people also looking at the GFR.
Thank you so much, sir. That detailed explanation. Next question to Seetharashmi ma'am. Madam, you have given a fairly very good detail about the renal biopsy. I would like to ask you, are there any challenges that when we have actually decided to biopsy a patient and you have the renal biopsy report, what are the challenges faced and overcoming these challenges once we get the renal biopsy report of the patient, how does it help in correlating with the clinical and biochemical findings as well as prognosticating the patient? Can you shed some light into that?
I know that's a good question actually. I always fight with the nephrologist sometimes to get give me a maximum history available. So we have a standard request form which includes all the clinical findings, the basic biochemical test, and before the biopsy is done, they have an indication definitely. So without an indication, no biopsy is done. So I have to find out what it is, where it is. So if a biopsy looks perfectly normal glomerulus, normal tubular interstitium, normal vessels, I cannot write it as a normal biopsy. Okay, because it is done with an indication. If he has done it with a nephrotic syndrome, there is something which is not detectable by light microscopy or immunofluorescence. So I have to suggest an electron microscopy to see whether there is what is the change in the podocytes. Okay, so in minimal change, the only change will be the effacement of food processor podocytes in the electron microscopy. So like that, there are other situations. It looks normal to me. Glomerulus, tubular interstitium and vessels are normal. But if he has done it for a hematuria isolated hematuria, the patient may be having a hereditary nephritis, Alport syndrome or something like that. Again, I have to ask for the genetic test and electron microscopy to see the basket weaving type of basement membrane and all. So in the other situation, sometimes like the patient may be having a subnephrotic proteinuria, maybe some edema, hypertension. Then the differential is between focal segmental glomerulosclerosis and IgA nephropathy. IgA nephropathy is the most common glomerulonephritis which is causing these symptoms. So that need biopsy to tell that there is a segmental sclerosis, but there is IgA also in that. So that's an IgA nephropathy causing a segmental sclerosis, not a primary FSGS. The other situation is a membranous glomerulonephritis. Membranous, you have so much of antigen targets now to demonstrate. So you have to have a biopsy. One easiest way is to do the serum PLA2R and exclude the primary membranous. But if that is negative, you have to have other antigen panel to say that why this has come. So that also needs biopsy. Then the other very important
face cream.
Yeah, we have a lot of other cases of membranous nephropathy which are NEL1 antigen positive. That is basically due to alternate medicine treatment and some treatment face creams with mercury containing face creams and all. So all those conditions we have to prove that it is due to that. Then one thing we just missed is the RPRF picture, actually rapidly progressive renal failure. So that also clinically, somewhat they will decide whether it is glomerular, tubular, interstitial or vascular. Sometimes it is very difficult if it is a combined injury. So the biopsy clearly tells you that where is the exact site of injury, whether it's a glomerular injury or a tubular interstitial injury or a vascular injury or a combination. And the further classification of the glomerular injury is based on immunofluorescence. If it is a rapidly progressive glomerulonephritis, you have to do the immunofluorescence to tell that whether it is something like a anti-GBM disease, or it is due to an immune complex disease, or whether there is no immunoglobulin or nothing in that, it's a post-immune vasculitis. So further classification is based on immunofluorescence, so you need a biopsy for that. Then the other thing is vascular diseases. When there is hypertension, if it is a very high hypertension, it can precipitate something called a thrombotic microangiopathy. So that will be an additional finding sometimes with these diseases. Then the difference between sometimes the renal failure, they know that it is tubulointerstitial somewhat, not much proteinuria, but renal failure is very high. So the distinction between sometimes the acute tubular injury causing a high creat, or whether it is an acute tubulointerstitial nephritis where they have to use maybe steroids, or the other thing is supportive care. So that needs a renal biopsy. So we can clearly distinguish this ATI versus acute tubulointerstitial nephritis, because you will see a lot of edema in the interstitium and inflammatory cells in the interstitium in ATI, acute tubulointerstitial nephritis. Then these are the areas in which we face challenges, but we are happy to see the biopsy, because we are giving an answer to them, a clear-cut answer to them, whether it is glomerular, tubulointerstitial or vascular, or it is a combination of this. And the other important thing which we convey is what is acute and what is chronic. So almost all the acute changes are reversible. So it's a reassurance when it is acute tubular injury, and if the cells have started regenerating, tubules are regenerating, we'll tell them that this is regenerating. So that's a area in which they can have some prognostication, and they can tell the patient that this will reverse. And once there is a lot of global glomerulosclerosis, lot of tubular atrophy, interstitial fibrosis, and hypertensive vascular changes, those part is almost like an irreversible change. So that also prognostication is possible. You can suggest renal replacement therapy and plan for a transplantation. All those findings are helping them to decide on that. And there is another vast area of transplant pathology also, where they need biopsy in lot of settings of the transplant evaluation and the immediate delay in if the function is not improving, or if it has come to normal then it is deteriorating, then they do a biopsy. That's a totally different, very vast area of renal pathology. So we work hand in hand, and definitely if they are doing a biopsy, there is an indication. We have to find out the reason for that and correlate with all the biochemical findings and the clinical picture. And we usually have what is called a CPC, clinical pathology correlation meetings for that. So that gives you a fairly good diagnosis and help in prognostication and your input into that. So,
Concluding statements.
As Dr. Sridhar rightly said, basically, nephrology is one specialty wherein almost there is a marriage between the nephrology and the pathology department. It's almost like that. We complement each other, we fight each other to come to a diagnosis. Not fighting is not quite often, but it is in the positive sense. So as she rightly said, it's very important that we give them the correct and detailed information regarding the patient's clinical profile.
Especially all the biochemical
and
serological tests.
Basically we have to look at the patient's clinical profile, what are the clinical findings, what is the patient's blood pressure, what is the patient's duration of symptoms, what all symptoms, and what is our clinical diagnosis, and what is the intensity of the kidney involvement from the biochemical investigations. And from the biochemical investigation itself, we will get an idea what is the probable compartment which is involved, probable, and what is the intensity of the renal dysfunction, and how the patient is improving or not. That only, we are not doing the biopsy, we can see whether kidney is improving or not. So improvement is basically from the biochemical test. That is also very much. So everything goes hand in hand. So that is very important. So I would like to say that, see, nephrology is one specialty where your investigations and your clinical skill has to be correlated extensively. It is basically a science and an art both has to be actually go hand in hand. It is science, it is more of a science. You can argue that it is more of a science. You can argue that it is more of an art also. And it is a team work. Nephrologists alone cannot make decisions often. So it is very important to understand that a kidney issue is usually unraveled from investigations, from after testing. That is the reason. So a diabetic patient, often we see people coming, sir, I have diabetes for so many years. I don't have any problem. My sugars are under very good control. I am seeing the diabetologist and my sugars are under very good control. He has advised certain tests, but why should I do it? I don't have any problem. I am passing urine properly. I don't have any issue. My urine is clear. But the matter is not ending there. You have a microalbuminuria can be only detected by a test. So testing is important. Any person who is, we usually said even issues can occur less than 30 years, but we practically we said any person more than 30 years has to have an annual ultrasound, urine routine, and a renal function test to make sure that he is not having any renal disease. So that is the first thing which I would like to say. If there is a family history, yes, he has to probably test this even before. And the basic test includes a renal function test, the biochemical test, as she has completely and extensively alluded to, urine evaluation test. If you go through the urine test, you can see one glance we can say that okay, these are the problems. But if you go into detail, a lot of information. One urine routine test is actually close to 2 pages. You can see our report. Lot of information. You can have actually a class on a patient's urine routine test. What all information you get from the urine routine. So that is very important. So for the nephrologist, the first test is always urine. Often we see that a patient who is being evaluated in detail for a kidney test, kidney issue, urine test is not done. Urine test, creatinine is done so many times, potassium is done so many times, but urine test is not done. So it's very important that any patient, if you want to have a renal evaluation, the first test is creatinine is definitely there, but urine test has to be done. You see a lot of patients who is having hypertensive, patient is on ARB for a long period of time, no urine test, no creatinine, no potassium. Patient is coming to you with a creatinine of 3.5. Sir, you are taking telmisartan. I am taking telmisartan for the last 5 years. Have you checked the creatinine potassium? No, I have not checked. Maybe my doctor has told, I have ignored, or even the doctor has not told. So it is very important to test a hypertensive patient for renal dysfunction. Again, the test is very simple. Urine routine, creatinine. Ultrasound, first screening. Ultrasound is something, see, a person coming to you. Patient is telling that, sir, I am having hypertension. Patient is taking drugs. Hypertension is not getting control. You are escalating the medications, adding more medications, seeing the blood pressure is still not under control. You have not done an ultrasound abdomen. You do an ultrasound abdomen and see that patient is ADPKD. You completely miss the diagnosis if the ultrasound is not done. So it is very important that a renal evaluation is never complete without an ultrasound abdomen, which might tell you one kidney is completely scarred and shrunken, other kidney is normal. He got the diagnosis. There is a solitary functioning kidney. It may be renovascular hypertension. It may be chronic pyelonephritis. It may be congenital hypoplastic kidney. Hypertension is due to that. So ultrasound is very important. Of course, ultrasound with renal Doppler to make sure that you are not dealing with a vascular issue. So that has to be borne in with hypertension patient. So diabetes and hypertension goes hand in hand. Now a patient comes in, walks in with a renal syndrome, like an acute glomerulonephritis, nephrotic syndrome, AKI, or maybe a CKD. So we have to first differentiate what is a syndromic diagnosis, and based on that we have to evaluate and make sure that you get the diagnosis. If the diagnosis is not complete with urine test, ultrasound, biochemical evaluation, and further clinical assessment, you have to go for a kidney biopsy and then find out exactly what is what. So kidney biopsy is always the final test, and the pathologist always has the last laugh, and we are all always happy to see that laugh. Thank you.
Thank you so much, dear Rajesh sir, Sita Lakshmi madam, and Dr. Pooja, the expert panelists, for giving a taste of your immense clinical experience and knowledge. Vertical integration, truly meaningful in the sense of the word. So with this, we are coming to the end of today's vertical integration session. Thank you.
Thank you.